Hi guys, today we'll be talking about Tinel sign, why it occurs, and advancing and static Tinel sign, and how and why they are called. So we know about the nerves. They're covered by a series of layers, the three layers to be exact. So whenever there's a nerve, it's covered by an outermost layer called the epineurium, and inside the epineurium is the perineurium, and inside the perineurium is the endoneurium. So, coming to the epineurium, it is the dense connective tissue portion which makes the fibrous coat of the whole nerve. And also, you can see this in the diagram. Also, this white substance in between also is epineurium only, and this is the loose connective. So, the epineurium has an outer fibrous coat and also loose connective tissue which fills the portions between the bundles of nerve fibers. You can see these are the bundles of nerve fibers. All this is epineurium. The outer coat is also epineurium. It contains the blood supply of the nerve called the vasa vasorum, and it is an analog to the dura mater of the CNS. So any damage to the epineurium does not hamper physiological nerve conduction because nerve fascicles are still intact. Perineurium. So the perineurium is made up of about 1 to 15 layers depending on the thickness of the bundles, and physiologically any damage to the perineurium is not compatible with nerve conduction. You can see these are the nerve bundles, and the coverings of these nerve bundles are made by perineurium. Each fascicle, let's call these nerve bundles fascicles. Each fascicle is surrounded by something called a perineurium. You can see this is the perineurium. And inside each fascicle, each nerve fiber is covered by something called endoneurium. So we'll come to that again. The main role of perineurium is to maintain the intrafascicular pressure. So it provides a good structural protection against penetration and crushing injuries. That is the perineurium. And it's also very dense around areas where the nerve crosses the joint. So whenever we flex and extend joints, the nerve does not get stretched, and it's thickened in these areas. And it is an analog to the arachnoid membrane. Epineurium is analog to the dura mater. This is an analog to the arachnoid membrane. And of course, endoneurium will be an analog to the pia mater. So this again here, each small nerve fiber is surrounded, each axon we'll say each axon is surrounded by endoneurium, and also the substance in between each axon is also endoneurium. So epineurium, the structures in between each fascicle also called epineurium. The nerve coating around the fascicles is called perineurium. The coating around the axon is called endoneurium, and in between the axons also is endoneurium again. And this resists elongation or stretch injury and protects the integrity of the individual axon which it invests. So how we imagine a nerve is like electrical cables running through, but the fascicles arranged in a nerve fiber are not like that. They are arranged in something called a plexiform arrangement, and it's not like the cable structure which we often imagine. And as you can see, the funicular anatomy changes every 1 to 15 meters. You can see it just crosses. So as we go from one nerve to another, one part of the nerve to the other, we can see each axonal, each bundle of nerve fiber, or each fascicle intertwines with each other. So from this fascicle, a few axons will go to this fascicle, and then from this fascicle, a few axons will go to this fascicle. It is a very mixed and random fashion, not the cable arrangement which we have in our minds. So the ways the nerves are either stretching, ischemia, compression, laceration, and by burning. One important thing is, so if a nerve is injured at this level or transected at this level, one node above is absorbed and everything below gets resolved. You can see calpain is destroying it, and everything below that level gets totally destroyed. And what happens is this proximal nerve fiber, which is still intact, tends to give axonal sprouts. And these axonal sprouts eventually reach the end, and again nerve conduction can be re-established provided a few conditions, which I'll be explaining. Coming to the classification of nerve injuries, two classifications, Seddon's and Sunderland's. Seddon's classification, just three types: neuropraxia, axonotemesis, and neurotemesis. Sunderland 1 is neuropraxia, Sunderland 2, 3, 4 is axonal emesis, and Sunderland 5, 6 is neurotemesis. If you want to compare the two classifications. So neuropraxia is just a local conduction block where there's only disruption of the surrounding myelin sheath of the nerve. Only the myelin sheath is disrupted, all the axons are intact. Axonal emesis, only the axonal discontinuity and myelin sheath disruption. All nerve fiber, all the nerve layers are intact. Endoneurium, epineurium, and perineurium are all intact. Sunderland grade 3, axonal discontinuity and endoneurial discontinuity, whereas perineurium and epineurium are intact. Sunderland grade 4, endoneurium, perineurium, and axonal discontinuity, whereas epineurium is intact. There will not be conduction, obviously. And in neurotemesis or grade 5, epineurium, endoneurium, perineurium, everything is damaged along with axonal discontinuity. Whereas grade 6, there's mixed nerve damage across the length of some part of the nerve will be grade 1, grade 2, some part will be grade 3. That's called a Sunderland grade 6 or mixed nerve damage. Okay. So I'll explain each of those again so that there's no confusion. So what is Tinel sign, also called Tinel-Hoffman sign? So when there's paresthesia experienced along the nerve distribution on gentle percussion of the course of the nerve. So suppose it's a median nerve, we know if we percuss along this line, along the line which the nerve we expect to be, there'll be a tingling sensation or paresthesia when percussed from distal to proximal. And this is used to evaluate nerve regeneration and to what level the nerve has regenerated. The most important point about Tinel sign is it is due to bare, young, hyperexcitable, unmyelinated sprouts from the injured proximal end. So from the proximal end of the nerve, like I said, with the distal end undergoes Wallerian degeneration. So from the proximal stump, there'll be some sprouts forming, and these sprouts are nothing but unmyelinated, hyperexcitable sprouts, which means even with light stimulation, they'll get excited, which is what the tapping does. By tapping, we're stimulating, exciting these young hyperexcitable nerves. And it is a clinical inlight sign for any nerve that has sensory fibers. This does not hold true for motor fibers, only sensory fibers. Another important point to keep in mind. So in neuropraxia, where there's only a variable amount of myelin damage and only a localized conduction block exists, all the axonal continuity is present. There's no scope for axonal regeneration as there's axons only not damaged. So Tinel sign will be absent as axons are intact. Okay. Axonotemesis, axons are cut and all the other nerve layers are intact. So Tinel sign will be positive because if an axon is cut, the distal part of the axons, suppose an axon is cut at this level, the distal axon will fully undergo degeneration. So from the proximal axon, there will be sprouts. And when these sprouts occur, Tinel sign will be positive. And axonotemesis recovery is usually complete as all the nerve layers are intact and they'll guide the axonal sprouts to the distal stump. Grade 3 Sunderland, axonal injury associated with endoneurial injury. So there will be some mild endoneurial scarring, but more or less the proximal axonal sprouts will be able to reach the distal end, and in most cases there is clinical recovery, but again it's variable and depends on certain things. Tinel sign is characteristically positive. So again, if it's regenerating well, Tinel sign will be advancing. What I mean by advancing Tinel sign is, suppose the nerve is cut at this level, and if we percuss from distal to proximal, Tinel sign will be positive here at one point. Then, after a few days, we percuss from distal to proximal, Tinel sign will be positive here, which means the nerve is growing from proximal to distal. So every time you percuss, the Tinel sign is advancing, which means it will be positive here, here, and then eventually the whole nerve regenerates. So initially it starts off being positive at this level. Then as the nerve grows, again it will be positive here. So as the nerve keeps regenerating, the Tinel sign will become more and more positive, more and more distally, which indicates nerve regeneration. Grade 4 Sunderland. Here the nerve axon is cut, endoneurium is damaged, and perineurium is damaged. And there'll be a lot of, once the perineurium is damaged, there'll be a lot of scar tissue. So the axonal sprouts from the proximal stump will not be able to reach the distal stump properly because they'll be misguided and they'll go in all directions and not go where they're supposed to go. So Tinel sign, so at the level where the nerve is cut, the Tinel sign will be present because the nerve will attempt to form the sprouts, but the sprouts will not be able to progress forward. So Tinel sign will be positive at the level which the nerve is cut, and it will not progress. It's called static Tinel sign. Okay, then there's usually no clinical recovery in Sunderland grade 4. So, and again, I'll just talk about Sunderland's grade 5, where neurogenesis, the entire nerve is cut, so there's no scope for axons regenerating and growing. So Tinel sign will be static again at the place proximally where the nerve is cut. Okay, so interpretation of the sign. Non-progressing Tinel sign indicates interruption of nerve regeneration. It's also called static Tinel sign. It occurs in Sunderland's grade 4, 5, 6, 4, 5. 6 is variable, so we leave 6 out of the discussion. 4 and 5. And sometimes even in 3. Advancing Tinel sign is seen only in grades 2 and sometimes 3 because the axons regenerate and they have a clear path to reach from proximally to distally. So we see advancing Tinel sign. So this is a master chart showing the same thing. So you can see recovery potential is full in Sunderland's grade 1 and 2. 3 is slow, sometimes it recovers fully, sometimes it doesn't. And 4 and 5 is poor to none, poor or none, almost. Okay. And so no estimate of motor recovery should be made from Tinel signs that indicates sensory recovery only from sensory sprouts. Okay. I hope Tinel sign is well understood. Thank you.